Oh, thank you very much, Dr. Parks. Yeah, welcome everyone to today's webinar, Find the Source of Chronic Pain. As Dr. Parks said, I'm the owner and administrator of Chronic Pain Champions. It's a resource center and a support group to help people with chronic pain take back their lives and improve their pain experience. And you can find me at chronicpainchampions.com and all the resources that I have available on that website. Today's webinar will last about an hour and will include some time for questions and answers. Feel free to ask those questions either using the chat feature of the event, I believe is correct, or at the end of the webinar. With that said, we do have some similar background, Dr. Parks. We both have a pain rehabilitation background, as I went through the Mayo Clinic pain rehabilitation program, and I love the idea of pain rehabilitation. So I'm really excited today to introduce you to Dr. Evan Parks, who will lead today's discussion about the neuroscience behind chronic pain and what you can do to manage it. Dr. Parks has worked at one of the largest pain rehabilitation programs in the USA as an assistant professor at Michigan State University. Featured in national media, Dr. Parks is a writer for Psychology Today and has authored the book, Chronic Pain Rehabilitation, Active Pain Management to Help You Get Back to the Life You Love. I've read the book, highly recommend it. Please join me in welcoming Dr. Parks.
Thank you very much, Tom. And what I'll be doing today is walking us through a presentation that gets at the idea that our nervous system, our central nervous system, our brain and the spinal cord are key to really understanding what is happening when somebody experiences ongoing persistent pain, past acute pain. So what I'm going to be doing is sharing some slides with you, and I trust that my slides are able to be clearly seen and you can hear me. While we're doing this, just the way that it's set up, I'm going to be admitting people into the group while we're moving along here. So I will hopefully be able to both talk and do some admitting, and at some point I'll probably just pause my admitting of people in part because I think I would be a little bit distracted. So what we're going to do is start with why I think it's important for us to talk about chronic pain and what is happening. So being a part of a pain rehabilitation program has been interesting. Many of the people who have been coming to our program have come in part because they have failed multiple times other forms of chronic pain management. And we've done kind of a survey of the population of people coming to us, and on average, about 12 attempts have been made to get chronic pain management help by specialists and including surgeries and spinal cord stimulators and medications and physical therapy, all kinds of attempts. And many of the people who are coming with chronic pain conditions often then feel hopeless. It's like, well, I've been through all these. Why am I coming to this kind of a program now? My doctor is so frustrated with me, they just sent me here, almost like they've been kicked to the curb. So what we're going to be looking at is how do we help people who have not only multiple failed attempts at treatment, but also multiple medical conditions. It's not like somebody just has an issue with their knee and nothing else going on with them physically. I mean, often there's many other comorbid medical conditions that are occurring, health problems. But people also have multiple pain conditions. Going back to that knee example, if they have some chronic pain issue with their knee, doesn't mean that something's not also going on with their back or their neck or They might have fibromyalgia or migraines in addition to that. And the pain itself can be often something that is interfering with their ability to work, but also interfering with their ability to be healthy enough to participate in life at home, and interfere with their ability to parent, to be a partner, to be a spouse, to be a caregiver. And people end up confused, right? What's going on? Why aren't I able to get, why am I not able to get the help that I need? And also shame. So I just received this email recently, and the email goes like this. I don't know the person who sent along this email, but this is what they wrote. I just returned from yet another doctor's appointment and feel very discouraged. Doctors do not know how to treat patients in pain. They don't even relate to us as real people. Each doctor I see can only do one thing, like cortisol injections for everyone he sees. If that doesn't work, they immediately send me to a surgeon or recommend more medications. If I go to the emergency room, I wait for 4 or 5 hours and then give up and leave. I understand why people with chronic pain just want to give up. I don't know if that sounds like an experience that you've had, but I think this email that I received from this individual, very frustrated, really represents what a lot of people with chronic pain have experienced. So what are we going to cover? We're going to talk about what is an overactive nervous system. We're also going to talk about how the central nervous system produces pain. That's the bulk of what we're going to focus on. And then we're going to talk toward the end on our thought processes. How does thinking about pain actually help? And that's something I'm very, very interested in. So I'm going to start us off with a quiz question. Now, you don't have to raise your hand or give a response to this, but I want you to think how you would answer this if I were giving you an oral exam and needed an answer from you. What would you say? I want you to picture back to your early years as a young person, maybe a teenager, early 20s, some point in your life, you developed a wonderful, warm relationship with a person that you're really interested in, and you find out, sure enough, they're interested in you. And this is your very first romantic kind of attraction to somebody. And picture, a 14, 15-year-old kid on a school bus at the end of a long day, maybe a field trip somewhere, and it's dark and it's late at night, and these two kids are on the back of the bus, and this guy reaches over to this special person's hand, and they hold hands for the very, very first time. First romantic crush, right? And this warm rush runs through that person's body, electric shock kind of feelings, and they have intense pleasure in their hands. So here's your question. Do you have pleasure sensors in your hands? So think about that. You experience pleasure holding a baby. You experience pleasure with a puppy or a kitten. You experience pleasure in your romantic relationship. So do we actually have pleasure sensors in our hands? We obviously experience pleasure with our hands. Well, the answer to that question is no, we don't. We do not have pleasure sensors in our hands. So then that leads to the next question. How then do we experience pleasure? Because we do. So you might have seen this illustration at some point in your life, and maybe back in high school, you had a biology class and you're learning about vision, and we have this idea, if you see a tree, tall pine tree, it enters our eye, goes to the back of the eye, the image flips around because of the lens, that upside down image goes to the back of our brain, optic nerve travels, takes that information to the occipital lobe. And then we are told, based on this image, that this upside down image then is in the back of our brain. Now, this is so reduced down to a simple illustration that this model that you see here is actually really inaccurate. So a person can have a stroke, a brain injury, some other kind of damage to their brain almost anywhere in the cortex, and it will affect vision. Because straight lines, horizontal lines, squiggly lines, texture, depth, movement, color, shapes, all of these things are represented in different areas of our brain. And it is really next to impossible for neuroscientists to understand how a single image then is actually formed. Because vision is not just this one little spot in the back of your head. It is actually something that is like a matrix throughout your entire brain. And we're going to talk about pain being the same thing. When I initially learned neuropsychology in graduate school, I was told that there's a motor cortex and a sensory cortex, and pain is just like this one little spot, in sensory cortex area. And that is actually not how pain works at all. So what is an oversensitive nervous system? So this is our first bullet point that I've mentioned here. What is that? So I use a very simple visual illustration, and it goes like this. Picture a floodlight of a motion-sensitive device with a motion-sensitive device connected to it. So you see the little circular thing there, semicircular, and you see the light bulb. So picture sitting in your in your family room at night, and you have this floodlight on the back of your house, and it's dark at night, and you're reading a book, and it's pitch black out the window, picture window, and then boom, the light turns on, and you look outside, and there's a raccoon or a deer walking through your backyard, and you go, oh, that light is working correctly. Now, the next night, you're doing the same thing. You're reading, it's pitch dark outside. The light turns on, you look out the window, and there's a single teeny little leaf going through that yard. Well, you wouldn't say, oh, my floodlight is working. You would say, my floodlight is not working the way it should. It shouldn't be triggered by a single leaf blowing through the yard. It would be on all of the time. So when we talk about an oversensitive nervous system and how that relates to chronic pain, we're talking about a nervous system that is getting triggered to produce pain when it should not be triggered to produce pain. So one of the differences between acute pain and chronic pain is acute pain is useful information. It tells you something. You have a cut. Chronic pain is the nervous system triggering this threat response and producing pain when it's actually not useful. So let me give you another visual illustration here that might relate to something that you have gone through yourself when your nervous system itself has been overactive. So picture a young couple. They meet in college. They get married after college. They start their careers. They work 3-4 years. They buy a little house, and they're like, let's start a family. So the wife is pregnant, and now picture the nervous system. So this couple, every night that they go to bed, is sleeping soundly. And while they're sleeping, their nervous system is protecting them. So the brain is listening for sounds outside, sounds in the house, temperature changes, vibration, pressure, touch, movement, activity. And cats meow and dogs bark and motorcycles go screaming by and the wind comes and rain comes and the shutters rattle. And these people sleep soundly because their nervous system has a setting, and that setting is when you hear these things, this is not a threat. All right. Now, the day of delivery comes, pregnancy is over, the baby is healthy, the couple brings the baby home, they put it in a little bassinet next to their bed in their bedroom. Now they go to sleep and they're exhausted. And now, though, their nervous system is recalibrated. It has a brand new setting. As they fall asleep and they fall into this deep, deep sleep, they hear the teeniest of sounds of this baby moving or taking a deep breath in or whimpering. And boom, not only are they awake, but they're just like flying out of bed. What happened to their nervous system? Their nervous system now has a new setting. It says, okay, whatever happens in the outside world, pay attention. It might be a threat. Threat to, the life and safety of your baby. Then that becomes their new setting. So this actually happened as my wife and I had children over the course of our marriage. So our very first baby's born, and 3-4 weeks into the new stage of being a parent, my wife and I are up, every 2-3 hours with the baby. And, I'm really excited, but then I really get tired. And I'm going to work every day and I'm starting to get sleepy. I'm starting to fall asleep at work. And then all of a sudden, I don't know how it happened, about 3 weeks into this, boom, my nervous system got recalibrated to its old setting. And I would go to sleep. My wife would go to sleep. The baby would cry. I would never hear it. And I'd wake up in the morning having slept, 7-8 hours and say, hey, honey, how was your night? And she would just kind of glare at me like, how could you not know? And I knew nothing. My nervous system had gone back to its previous setting. And so when we help people with chronic pain, that's actually what we want to happen. We want the setting of this is not a threat, this is not a threat, to come back to that person's nervous system. So here are 2 pieces of information about pain that you want to keep in mind, the difference between acute and a chronic pain. So acute pain typically is associated with an injury, and we know what it is. We know where it came from. We know when it started. And you know that there's tissue damage, and you know what kind of treatment works for acute pain. That's the advantage of understanding acute pain is people can get specific help. So in this image, you can see this lady is actually using a single finger to point to something. I think it's just the accident of or the setup of the photographer. But in my work, when people use a single finger to point to an area of their body, they're generally talking about an acute pain issue. They don't realize that. But when people use their entire hand and they go like this, it's likely they're not talking about acute pain. They're talking about chronic pain. So chronic pain usually lasts longer than 3 months, but the cause is not always known because it's not clear when it started. It's very clear that the kind of treatment that is useful for acute pain isn't very useful for chronic pain. And there might not be any corresponding tissue damage. So people are then left with, well, what is happening? And that's why we're going to spend a lot of time. So as you read about this, and if you read any specialized literature on chronic pain, you're going to read words like nociceptive pain and neuropathic pain and nociplastic pain and central sensitization. I think those are helpful words, but in our presentation today, we're just going to be talking about the difference between acute pain and chronic pain, just to kind of keep everybody on the same page. So in our experience day to day, when we have sensory input, so we have a peripheral nervous system running through our body, and we have information that comes. So if I were to use a straight pin and poke myself, I would have a pain sensation. So you think of that almost like a switch, right? It starts and it stops. So you have sensory input and you have sensory output right away that, ooh, that hurts. And it seems like pain is that simple. That's our experience anyway. Well, I wish it were that simple. And it's not. It's actually a little bit more complicated. So let me get into how we actually think is what's happening. So we have peripheral nerves that provide input. So you might be aware that we have head to toe wiring of our nervous system that's feeding the brain and the spinal cord information. So the two words that are used are peripheral nervous system and central nervous system. So the input comes from the peripheral nervous system, this 43 miles of wiring that we have. The analysis is our brain and the spinal cord. It's trying to figure out, well, what is that? And then the brain says, okay, if this is a threat, we better make this person aware of what's happening. And that awareness comes in terms of a sensation or some kind of output. And we're going to find that pain is just one of many, many options that the brain can use to get somebody's attention. So going back to that pleasure question, you have sensory input and you have the brain and the spinal cord analyzing that. What is happening? What context? What does this mean? And the brain produces a sensory output, which is pleasure. Same thing with pain. So here it is represented another way. So we have sensory input, we have analysis and output. So this means that without the brain being involved, that sensory input is not going to be experienced as anything unless the brain says something about it. So let me try to give you an example of that. Let's say that you cut your finger while peeling some vegetables, and you are aware of that tissue damage. And that tissue damage creates this sensation of pain because your brain says, oh, yeah, you shouldn't have that. So you're motivated to go get a Band-Aid. But let's say that you have a cut finger that occurs at the very same moment that you break one of your bones in your leg. All right. If that happens, your brain is going to decide what you need to know. Your brain will not tell you anything about your cut finger, and it will tell you, pay attention to that broken leg. Why? Because it doesn't want you walking around on a broken leg looking for a Band-Aid. So this actually happened, not that event, but another kind of tragedy happened with my parents. My parents were driving through a small town, not going very fast for the speed limit of that town, but somebody drove into them head on that had fallen asleep while they were driving. So my mother had a broken pelvis, rushed to the hospital. My dad's back was broken. So I'll talk about my mom here for a second. So the first 3 days in the hospital, they're just trying to get her medically stabilized. And then they did surgery to repair her fractured pelvis, with pins and screws and things like that. And you asked her, when I asked her about her pain, she said, oh, my hips and my groin and my pelvis, all of this area is just, horribly, horribly painful, right? Now, 5 days after the accident, she says, oh, I find it hard to breathe. My chest really hurts. What's going on with my chest? I wonder if I have pneumonia. So they give her chest x-ray and she had all kinds of broken ribs, right? Well, she had broken ribs for 5 days. But her brain didn't tell her anything about that. She's still in the hospital 7 to 10 days later. Now she's out of ICU and into, a longer term care. And she says, my knees hurt, my forehead hurt, my shoulders hurt. And she developed bruising in these areas. Well, she had been hurt 7 to 10 days ago now. And now this pain related to hitting the dashboard, hitting the steering wheel, hitting the side door, all that pain starts to show up. What her brain was doing is saying, this is what you need to focus on. Now, this is what you need to focus on. And now this is what you need to focus on. It's a marvelous system that our central nervous system has of giving us the information that we need when we need it. So it's not as simple as saying there's sensory input and there's output. So how do we know this? If you're skeptical, still, let me give you another illustration. Here's an interesting one. In the course of my work, I've seen many people who worked in industry, skilled trades, factories, farms, who have lost a hand, lost a foot, lost a leg, lost an arm. And sometimes many months after the loss of that limb or that hand, they have an occurrence of pain. And then this pain becomes worse and the pain becomes chronic. So there is no sensory input, right? There is no peripheral nerves giving the brain that information. So the problem has to be in the central nervous system. The other example is a very complicated medical condition called chronic regional pain syndrome. That's what CRPS is. CRPS often occurs after a crush injury. I've seen many of these people who have been in a car accident, for example, or been crushed by a press, maybe in a factory. And picture not just a fractured forearm or something like that, or a leg, but picture a dozen or 2 dozen hairline fractures all throughout that bone structure. It's in place, it's intact, but it's just been crushed. So, of course, they go through, normal medical treatment, and they have a cast, and they have 3 months of healing, 4 months of healing. And then subsequent to that, they develop this very terrible pain syndrome where their skin will change color and it will change temperature, and they'll be so sensitive to any stimulation on that they can't wear socks or shoes if it's in their lower limb. And very, very difficult. And so what I have seen during the course of our treatment of these people, that the CRPS that's, let's say, in their lower left limb will transfer completely 100% to their right limb. So when you look at the physical structure of their right limb, there's nothing there. There's no crush injury. There's no trauma that had occurred, but the entire pain syndrome transferred to another limb. So when that happens, the only explanation that we have for that is this explanation that I'm going to walk you through of what's happening in the central nervous system. So when the central nervous system is off, we just don't find that somebody has acute pain or chronic pain. They're sensitive to all kinds of other sensory input, just like an oversensitive floodlight, right? They're sensitive to light or to sound. They're more easily fatigued. They have burning sensations, tingling, numbness, nausea, maybe even vomiting, dizziness, loss of consciousness. All of these things can be occurring with their sensory system. And so they'll go to different specialists looking for explanations of what's wrong with my vision, or what's wrong with my hearing, or what's wrong, with my fatigue, or, why do I have this burning sensation? And they'll get different explanations that really don't account for the central nervous system being off. And the same thing with the motor system, right? Tremors, muscle spasms, muscle twitching, cramping, non-epileptic seizures, partial paralysis, full paralysis, breathing difficulties. So let me try to bring this back to the oversensitive nervous system picture. When I was a teenager, began to drive, age 16, like some young people, I was adventurous and thought it was great fun to be able to drive. And I was also a bit reckless. And I remember coming home one day having crushed the whole side of the car against a tree and tied the door on with some rope. And my dad was standing in the driveway waiting for me. And my dad, very patient, very calm, very kind and loving man. I mean, he stood there and listened to me tell this account of what happened. And his eye was twitching. I can still remember it to this day. He was so mad and so frustrated. His nervous system was overloaded. So do you think it would have been appropriate for me as a 16, 17-year-old to say, hey, Dad, you got this muscle spasm going on in your eye there. I think you should see a neurologist. No, that would not have been a smooth move on my part at all. But his nervous system was telling him that he's overloaded. He's under pressure. And it was telling him by actually creating what? A muscle spasm. It wasn't a disorder. It wasn't a neurological problem. But it was a factor of a nervous system saying, hey, pay attention. So when we have an overactive nervous system, what we experience is the spreading of pain being greater than what we'd expect for what's happening, kind of a disability that comes with the pain that's greater than you'd expect. But you're also going to see other things happening, which might be on the surface appear unrelated. Other autoimmune conditions, not other, but autoimmune conditions, such as irritable bowel or psoriasis or ulcers or asthma or dermatitis, dry eyes. So many of the people coming into our program are seeing multiple specialists for autoimmune conditions. So when we get toward the end of our presentation here today, we're going to touch on this because multiple systems are off when somebody has chronic pain. And we have to understand what's going on. So when somebody actually has chronic pain and you experience the pain sensation, what is it that you know for sure? Well, actually nothing. Think of it like an engine light that turns on when you're driving your car. That engine light turns on. What do you know for sure is wrong? Nothing. You know that the light is on. That's all. You could have a loose gas cap. You could have a catastrophic failure of your engine. You could have a loose fuse. You could have bad wiring or anything like that. So the other illustration that's often used that you might relate to as well is a smoke detector. When a smoke detector goes off in some remote part of a building that you're in, what do you know for sure? Nothing. That smoke detector could be malfunctioning. It could be triggered by dust. It could be triggered by steam. It could be triggered by a raging fire. But when you hear that sound of the smoke detector, you actually don't know what is happening. So when we experience chronic pain, we don't know. And so when the nervous system is oversensitive, it reacts to things. So have you ever swallowed a large pill and you swallow this pill and it kind of goes through your throat here, and 5-10 minutes after you have swallowed that pill, it feels like that pill is still in your throat. It's not, but you would swear from the sensation that it is. Or picture this, you've been in a movie theater for 2.5 hours watching a long movie, and you step out of that theater into the bright light and your eyes hurt. Does the pain of your eyes hurting tell you something about a problem? No. Your nervous system was calibrated to be appropriate for that darkness. And when that nervous system now has to recalibrate itself, it produces discomfort. But the discomfort is not something that can be fixed by medicine, right? You can't go to an ophthalmologist and say, hey, would you give me some medicine so my eyes don't hurt when I come out of a theater? No, you can't, because that's a function of an oversensitive nervous system, right? So how can I illustrate this with some research? So this is interesting. A professional violinist always holds the violin on the left shoulder. The neck is held with the left hand. Notes are depressed or created by depressing on the fretboard with the fingers. The right hand is always holding the bow. So let's apply some of the information that we've learned. So when somebody has an oversensitive nervous system, what I am saying is that that nervous system is off. So you can take the right hand of a professional violinist and subject that right hand to pressure, to tissue damage, to chemicals, to heat, to cold. It will hardly register any pain. You can do the same experiment with the left hand, and that left hand is instantly going to register pain. Why? In part because the brain looks at that left hand as something that is very important and needs to be protected. And that gives us a clue of what is happening when somebody has chronic pain. Their nervous system is looking at areas of their body, or maybe even their entire body, as needing protection. And anything that happens, any kind of movement, sensory input that occurs, then becomes viewed by that nervous system as a threat. So how does that happen? So I have an illustration here that we're going to take apart piece by piece. So don't feel like if you don't get this one image here, you're not going to understand. I'm going to take this piece by piece and explain each part. So we have sensory input. That's our peripheral nerves. That information, that's the purple one at the top. And then it goes to our spine and our brain. That's the analysis. And then our brain says, yes, there's a threat. And it produces an output, pain. Pain triggers an alarm response, which we're going to talk about. And that alarm response actually has feedback on how those nerves function. So that in the end, a person can end up having a system that maintains itself. How does that happen? So sensory input, sensory analysis, threat response, alarm response, keeps this cycle going. So we're going to go through each step. So step one is sensory input. So these are 5 types of peripheral nerves that we have. We have tissue damage nerves that say, hey, you have a cut, ligament tear, pulled muscle, skin, cut, something like that. Heat, chemical, anything acidic, lemon juice, tomato juice. Mechanical pressure, think of a disc pressing against a nerve. And inflammation. So we have these different sensors. So think of, the peripheral nerve being like my hand, my arm here, and then these different, nerve endings, are each designed to do different things. 43 miles. So, for example, every 5 seconds, approximately, everybody watching this right now is blinking. Why? Because you have peripheral nerves on the surface of your eye that are detecting dust in the air, particles in the air that are landing on the surface of your eye. And your nervous says, "Oh, that's not good." And it causes you to blink about every 5 seconds. When people have a disease that impairs their peripheral nervous system and they don't blink, what happens? They go blind. So we need the awareness, or our nervous system needs this awareness of what is happening everywhere in our body. And these nerves travel everywhere except for our hair and our fingernails. So our analysis, what is that? Well, our brain is trying to do two things. It's trying to explain what is happening, and it's trying to protect us from danger. So it has to do this analysis. So what we're going to look at is, how does this analysis happen? So we're going to go through some of these real quickly, and let me encourage you, if you want more information, the book that I've written called Chronic Pain Rehabilitation walks you through, as a reader, exactly what each of these are. But the brain will label something as good or bad, or you like it or don't like it. It will link it to a memory. Oh, what's happening now is just like what happened last week. That may or may not be true. Connection, we're going to talk about that in a little bit, just a second. But it links things that are occurring together in the present moment, even though they may not be occurring. It looks at past learning. What did this, how did this connection between a stimulus and a response occur? The brain will make predictions. It will say, oh, you're going to have pain for 8 hours or 12 hours, or you rake leaves on Friday, you're going to be out this whole weekend. That's a prediction. It will judge. It will point its finger at you and say, this is your fault. If you hadn't done this, if you had done this more, if you would be a better person. It will create a story. It will say, pain from now on is going to be in the driver's seat of your life, and you're going to have to ask permission from pain whether or not you can do something. It will ask questions. What if? What if I get worse? What if I end up in a wheelchair? What if I can't, continue to work? It will create rules that you have to follow. You must do this. You must not do that. So I'm going to walk through this and use just one for right now as an example of what the brain is doing. So the brain is trying to weigh evidence. Is there evidence for safety? Is there evidence for danger? It's making connections. It's trying to make sense of the world. So as you see these three dots, most likely your mind just did something that is automatic, that you couldn't stop it from doing. It looked at those three dots and automatically said, oh, triangle. Now, it kind of looks like a triangle. It's not necessarily a triangle, though, is it? It's just three dots. So let's now imagine that I'm talking with a person who has an aching back, and for 15 minutes after dinner, they stand in the kitchen sink and they're washing dishes. And while they're washing dishes, they look out a kitchen window. And that kitchen window, they see these dark clouds rolling in, and the wind starts to blow and temperatures dropping. It's going to rain. And their brain says, oh, three things are happening. There's aching back, there is standing, and there's weather change. These three things are occurring at the same time. Therefore, they're related. Now, they may be related or may not be related. But here's my point. Once the brain makes a connection, they're connected. Well, let me illustrate why that's a problem. So let's say I'm talking in my office with somebody who has some mechanical issue with their knees. And standing straight up, they're fine. Walking on level ground, they're fine. But going downstairs, upstairs, down a hill, uphill, a lot of pain. So I'll have them close their eyes in my session, sit back and visualize going down a flight of stairs in their house. What does that smell like? What does that sound like? What does that look like? What movement's happening? Do that for about 2 minutes. I'll have them open their eyes. And what will they say to me? My knees hurt. How? All I did is connect the part of their brain associated with that movement with the part of their brain that knows where that movement would happen and visualized it. And the brain says, oh, I know what goes with that. Pain goes with that. So in physical therapy, as people come into our program, many people have not been physically active in a long time. And they're encouraged to go out for a walk once they get conditioned a little bit. And they start going out for 5 minutes from their house and come back for 5 minutes after taking a break. And the first day that they do that, they come back and they're winded, and they wake up that next morning, they're a little bit sore. They go out that next day, they're winded again, and they feel sore. And the third day, they're getting their shoes on to go out the door, and they flare up with pain. What did their brain just do? Their brain just made a connection. They said, oh, walking is connected to soreness. Soreness is connected to pain. Probably it's not good for you. And shoes are linked to walking. So your brain doesn't wait for you to actually go out for a walk. It just creates the pain by making that connection. And that whole connecting thing can become like a spider web. So more and more things in a person's life and sensory experiences in a person's life become linked with pain. And it really doesn't need to be. But the connections are literally there in the brain. So another thing that happens, a part of the analysis, as the brain is doing this analysis, it stimulates our emotional system. Our emotional system is really important. It tells us good things that we need to know. It tells us what's out of place in our life. It tells us what's good in our life. So we want to not think of negative emotions as things that we should get rid of, but things that we should be aware of, because they're telling us something. So fear is triggered by what? A threat to ourself. It's triggered anxiety by loss of control, sadness by loss, anger by our goals being blocked, frustration from not being able to do things, helplessness from trying things that really don't work, and that helplessness leading eventually to depression and shame, feeling judged and negatively viewed by others. This emotional analysis, or this emotional response to the analysis, amplifies the sense that something's wrong. And then that balance system of the brain evaluating this information can get to a point where it says, okay, there's a threat. And it produces pain. That pain then produces an alarm response. What is that? Well, it triggers our stress response. Stress is anything that we have to adjust to. It's not negative things. Having really good friends come over for the weekend and stay with you is positive. Having a baby born is positive, but it's something that you have to adjust to. Well, when that alarm system is triggered, you're going to have increased muscle tension. You're going to have increased in hormones like adrenaline. You're going to have change in blood flow. So your hands become cold, your feet become cold, and blood goes through the core of your body. You're going to have increased pain, but you're also going to have a change in your immune system. So this takes just a second to explain, but is super important. So our immune system is a part of our stress response when there's a threat. So picture you're driving down the road and there's a near-miss car accident that happens right next to you. And in that flash of a second where you don't know if you're going to get hit, your immune system does not wait to find out if you're going to get cut. It releases inflammatory cells and white blood cells to protect you in the event that you are cut. Well, that's good, but an accident didn't happen. So you have these cells then in your body that are actually without a target. So imagine sitting on your couch and every 2 or 3 hours, you have a flare up of your pain. That flare up of your pain triggers your stress response. Your stress response triggers your immune system. Your immune system releases inflammatory cells that do what? Create inflammation of joints, tendons, ligaments, or maybe the lining of your stomach, or your intestines, or your lungs, or impact your thyroid, impact the glands around your eyes. So once that happens, we have a system then that is able to create its own self-sustaining loop. We have sensory input, sensory analysis, threat response, alarm response, and then in time, you don't even need that sensory input anymore, because this system, like I described it, will maintain itself. And that's persistent pain, chronic pain. And it's not telling us helpful information anymore. So what do we do? So these are some of the key steps that Tom is talking about all of the time on his group, Chronic Pain Champions. People normally, because of how we respond to acute pain, will stop moving when they have chronic pain. And you really need to learn that moving is essential for recovery from pain conditions, even headaches. And you have to learn that pain does not equal harm. That just because you physically are uncomfortable when you go out for a walk, it does not necessarily mean that that discomfort that you have is damage being done. We also have to look at the lack of positive emotions that people have. We know that negative emotions increase or amplify the stress response and amplify the pain response, and positive emotions are very helpful at reducing our experience of pain and other things. So to engage in activities and with people that will help you generate positive emotions, and to learn how to handle fear, how to handle anxiety, how to handle depression is key. And then behavior needs to change. Many times, people who have chronic pain have loved ones in their life who constantly ask them about it. How do you feel today? What can I do for you? Don't get up. I'll get that for you. And we encourage family members and patients to stop talking about pain. All that does is reinforce all of these connections that there is something wrong, something wrong, something wrong, something wrong. And you want to stop doing that. And you want to replace brain maps. So I'm going to close with this really quick. So picture that analysis that I talked about, like a balance scale, an old meat scale that you might see in a butcher's shop. And it's weighing evidence for danger and evidence for safety. And we all have evidence for danger, right? Your MRI, your CAT scan, doctor says it's the worst case I've ever seen. My medication hardly helps. If I move, it hurts. I've been told I have degenerative disc disease. My mother had the same problem. I'm not okay. We need to increase, though, the other side of the scale. We need to tell ourselves, coach ourselves, remind ourselves, pain actually does not equal harm. I am sore but safe. Motion is lotion, right? We need to move. I'm going to pace it, not race it, because people generally who have chronic pain have this moment of feeling good and then they try to do their whole to-do list. Don't do that. Always pace yourself. I can break the rules and be okay. You can go out to the mall. You can go shopping. You're going to be okay. I'm okay in getting better. I can have pain and be active. I can read my right brain. So in summary, this is how we want to rewire the brain. We want to increase knowledge, increase hope, and increase movement. And that will balance things in the favor of safety in me messages. So we covered a lot, and we have just a few minutes here to close it for time's sake. But I really appreciate, Tom, the opportunity to be here and be a part of sharing some of the information that you share on Chronic Pain Champions. Thank you very much for that opportunity.
And thank you very much for your time, Dr. Parks. And thank you for everyone for attending today. The